Good afternoon, everybody. My name is Jason Belden. I'm the Disaster Preparedness Program Manager for the California Association of Health Facilities. And with me today is...
Courtney Custerson. Again, I am the CAHFDPP Coordinator. And so welcome to Webinar 10 for the Los Angeles County Mutual Aid Program here, where we give you updates from the Disaster Resource Center meetings. And today we'll also be talking about the Nursing Home Incident Command System. If you didn't get my email last night, you can find today's continuing education evaluation under the handout section. And then there's also another handout on there that we're going to be filling out today as a group. So, and then joining us later will be Rich Widerynski. He may already be on the line. Rich, if you can hear us, feel free to chime in. And then Chris Sandoval from LA County Health Services as well.
All right, so we'll hop to the next section here. I'm going to go to the next slide.
Okay.
So we've got some updates in the few slides after this from the Disaster Resource Center. I know that there was a little bit of confusion. Rich told me that one of the DRCs had scheduled to have a meeting today that's actually going to be tomorrow. And so let me get that information. I apologize. He just emailed it to me. But if you went out to the DRC meeting today and there was nobody there, they're going to have that meeting again tomorrow. Maybe Rich can speak to that. But let's see here. It is...
I'm sorry if you see my mouse moving around. I'm just making sure that...
So the DRC in Valencia was rescheduled till tomorrow. So normally it's held on the first Wednesday, the odd months, from 9:30 to 11:30. But I guess the meeting got changed to tomorrow. So if you're planning on going, you certainly can go to the meeting tomorrow. I believe this is their HVA meeting, which is one of the meetings that we would request that you guys attend those. And if you're not able to attend those, certainly you need to provide your HVA to the DRC coordinator so that they can incorporate that into the community-based HVA that you'll eventually get. That's a requirement from CMS. So.
Right. Let's see, next slide. We have some acronyms here. So we put this slide in usually every PowerPoint, so we won't spend too much time going over these, but and we also try and type out all the acronyms for you here. And did I hear Rich or Chris join us?
Yes, Rich is here.
Hey, Rich. Was it Valencia? Is that the DRC that was scheduled today that is meeting tomorrow?
Yes.
Okay, perfect. All right.
So that's Henry Mayo, I think, correct? Yeah.
Right.
Okay.
But you know, excuse me if I may interrupt. I just pulled up something that says the HMNH DRC meeting has been canceled.
Oh, I saw those meetings too. I think that something happened with their Outlook item, and they sent out another email saying that it has not been canceled. So there's a little bit of confusion going there. But if you were planning to go to the Henry Mayo DRC meeting tomorrow, it is still happening.
Wonderful. Thank you.
So as we will kind of dive into throughout the whole PowerPoint here, it is HVA season. And so HVA, that stands for Hazard Vulnerability Assessment. And if you haven't completed one before, it looks like this spreadsheet here that will list a bunch of different hazards, and then you give yourself a score based on probability, severity, and then your own preparedness. And then a little update on the Hazard Vulnerability Assessment. On February 1st, CMS released a new AFL detailing that they want emerging infectious diseases to be added to this spreadsheet, and then begin scoring yourself on that. And so as you can see in the bullet point there, emerging infectious disease, that means Zika, Ebola, all those sort of exotic things.
Yeah, like influenza like ILI that comes from a separate country or something like that. So those kind of emerging infectious diseases, you don't have to list all of the diseases out. You can just put emerging infectious disease as a risk category, and then based on those things that you understand fall under emergency infectious disease, whether it's Zika or Ebola, ILI, or something like that, what is your risk of being exposed to that, and what is the risk of that appearing in your facility? You only have to have a policy and procedure for emergency infectious disease if you have scored yourself at being at risk of this happening. So if something like this, if you score yourself as even a moderate risk, you would want to have a specific policy and procedure that dealt with how to deal with emerging infectious disease. Unfortunately, this is not traditionally something that long-term care has really factored into our HVAs. So we don't have a policy and procedure or a template written for these type of things. Our best bet is to rely on some of our partners with the acute care hospitals and the DRC coordinators to see if there's language that we could borrow from them or something like that, some of the traditional stuff that we'd have to look at. So these are one of the things that we can really get from those folks at the acute care hospitals, because they all have ongoing policies for that. So the other thing that's mentioned in that AFL is some stuff on emergency power and things of that nature. I just want you to know those more relate towards people that plan on using temporary generators, since all of our generators are permanently installed to meet the needs of those subsistence needs that CMS calls for. There's just nobody here that's going to be pulling in like a Honda generator to power their building. So traditionally, other states, or not every other state, has a requirement that generators be used for long-term care. So for those states, that language had to come out to let them know that just because they're using a temporary system doesn't mean they're absolved of having to follow the NFPA Life Safety Code requirement. So, and then the last category there is planned power outage. We have utility failure on there. Traditionally, utility failure is something that has a short duration, we hope, unless it's accompanying another type of disaster like an earthquake or something. But a planned power outage is a little bit different in that we will get a range of how long we think the building's going to be without power. And with our utility failure risk assessments, or HVAs, I don't think we've really thought about a prolonged power outage. And some of these, if you're in, that says PG&E's footprint, but really it's PG&E or SoCal Edison. Those are the two large utility providers that have identified that they're going to shut off power if the wildfire risk gets too high. So, and those planned power outages could last a multitude of days depending on the forecast. So make sure that that's incorporated into your HVA.
Yep. Okay. So our next section is going to be the DRC updates, and Rich will give us some information on that. We're probably going to spend only a couple minutes on each DRC because we have a lot of good stuff for everybody today on the nursing home incident command system. So Rich, if you're ready, we'll go into these slides here. And
all right.
Sorry, go ahead.
But I'm kind of like not ready. For some reason it's not coming up.
That's all right, Rich. We can cover this. So at the Henry Mayo meeting on January 2nd, it was suggested that the facility's incident management team meet to determine if any changes have occurred, pertinent contacts, contracts, MOUs, and things of that nature, and then ensure all generators are in proper working order. I can't ensure that stress this enough. Our facilities cease to function without electrical power, so we need to make sure that our generators are able to sustain operations at least long enough to get us safely out of the building in worst case scenario. One of those things that it's not really mentioned in here, but is one of these things is a good best practice. We do a lot of testing on our generators. We're required by code to do periodic stuff. What's not required by code is to test a transfer switch, and the transfer switch is the one point of failure that changes you over from commercial power to emergency power. And so when we're doing our generator testing, or when we do that annual load bank test on our generators, think about incorporating testing the transfer switch if you don't already do it, because if that fails to transfer over the power, it doesn't matter if your generator's in working order. That's kind of the weak point, and that's where we see a consistent failure across the country in large disasters, is maybe not so much the generator, but the transfer switch which fails. So
yeah, and this would be on all of the radars of the DRCs, but also the surveyors, because of what Jason was just talking about with those planned power outages from the larger utility companies, which is kind of their new policy for mitigating some of these wildfire hazards. So just be prepared that might pop up for your surveys as well, because that's kind of the topic, hot topic for right now.
Yeah, and then it was brought up at the DRC that folks were looking for possibly a checklist or something like that to help them repopulate after a disaster. And we, with the help of OSHPD and licensing, put together a little checklist of things that you can think of before you repatriate or repopulate a building. Everything from physical plant stuff down to, have you restock supplies and things of that nature. So it's kind of a checklist is available. Anybody can download it off that portion of the website. And certainly we're open to comments on this, because we really relied on OSHPD and licensing to fill that information in. Sometimes there may be other things that you guys have seen through your personal experience of repopulating a building that we need to capture. So if you see something on there, please let us know that needs to be changed.
Okay, so the next DRC meeting, and Rich, if you want to jump in here, since you were the person there, they were discussing that the next tabletop exercise will be on flooding. And then we do get a lot of questions about the Great California Shakeout.
And obviously we encourage everybody to participate on that. This year it's Thursday, October 17th at 10:17.
Great, thank you. And Rich, we're getting a bit of an echo on your end, but it's not terrible, so we will keep going.
Yeah.
But one thing on here that I just wanted to point out to everyone listening, this is a really great opportunity to get involved with the DRCs, even if you're not attached to the Long Beach DRC. They're putting on this exercise in August, and they're going to need a couple hundred volunteers. They're going to be moulaging people, fake blood, fake victims. And so if you're looking for a way to kind of orient or get your staff interested, sending somebody or participating yourself, that's a really great way. I wish that I could attend that.
Yeah, I actually thought about flying down just to go do it. But certainly, if you guys are into that stuff, or if you're geeks like us, you go participate, because it'll be fun to learn. But
yeah, it's at the Joint Forces Base, so they're gonna. I think that I read they're gonna be using like helicopters. It's gonna be like the whole 9 yards. So if you want more information on that, you can shoot us an email, and I will send you more information.
And get you in contact with Kathy Dollarhide too.
Yeah, so. And her email's there as well.
And that external tabletop, they're talking about flooding. I'm not sure what the scenario is, but I do know that the statewide medical health exercise in November will be flooding, but I don't know. I don't know if Los Angeles County will also be doing that, but if they are, this will be good practice if you want to do the full scale as well. So,
is Chris on, by the way?
I haven't heard him come online, but
okay,
he'll be able to join us later.
Perhaps he knows about whether this was going to be adopted by entire Los Angeles County versus just a group.
Yeah, I think that I think it's probably more than likely they're going to stick with the statewide scenario, but I don't know that for sure. Generally, they start the planning process pretty far out, and they. If they're going to do something different, and they haven't indicated that they would be changing the scenario this year. So,
All right, up next, we have the PIH Whittier DRC. And so if you see your name on there as the SNF's president, thank you and congratulations for being a participatory member. So Rich, did you want to kind of fill us in? Anything that you wanted to point out at this meeting?
Well, as you can read, one of the things that was suggested was to place ReadyNet, the ReadyNet app on your phone for easier access so that you get in the habit of using it, you know how it works, etc. And you know, you can sell your staff on it as well.
Excellent. Exactly. Yeah. And I think you can kind of like set up getting text notifications as well on the desktop version and the mobile version, I think. So definitely worth the time to kind of play around with the settings on ReadyNet. And I think ReadyNet's going to be rolling out some new features, I believe in May as well. So it's a good time to kind of check it out, get it all updated, and we're going to be trying to really push more involvement on ReadyNet as well. And then that next bullet point there, so establishing some disaster goals for the year. We're going to kind of help everyone online today with updating your incident management team. So if you haven't already printed out or pulled up the handout for that chart there, we're going to be going over that more in depth later on in the PowerPoint, and then that'll be kind of the start for updating your EOP for the year. And
can I just want to mention something on the review of the EOP for you guys. Most of you, or a lot of you, know that CAHF and Los Angeles County EMS have hired a contractor to come out and do EOP reviews in your facility of your emergency plan. So they'll come out with a checklist to kind of go over some of the stuff with you. If your facility has not done that in the last 2 years, even if you've done it, but it was over 2 years ago, you still can qualify to have that done again. But you need to reach out to us, send Courtney an email, let her know the name of your facility, when you would like to have that review done. We do request, or the contract requires, that senior staff accompany them and participate through the review process with them. It makes it very difficult for the contractor to go out there and review an EOP without actually questioning the administrator. So the administrator or somebody from senior leadership has to walk through the review with them. But if you guys want to get signed up for that, just let us know. It is free. The county pays for it. It's not, it just takes maybe an hour or two of your time, and we'll prepare a report for you and give you an idea of some of the things that maybe you should be concentrating on going forward. So,
Jason, the other day I was at a meeting, at a DRC meeting in Los Angeles, and there were a couple of nursing homes there that had spent an inordinate amount of money developing an EOP because obviously they needed it. And when I told them that they were, qualified to have this available to them for free, they were just kind of blown away because they spent thousands of dollars on this.
Yeah, the contractor doesn't do it for free, but the county pays for it, so which is nice. Yeah. It's a part of the grant that we have with them. So I'm not sure how much longer we'll be able to do this. The federal government is pretty particular about what they spend their money on, and this is one of those things that we've, really kind of made a priority. I'm not sure how long the grant will continue to pay for it. So if you haven't done it, by all means, take advantage of the opportunity while you can.
Let me just add that today is the 6th of March. The year is just barreling along, and it is just wise to sit down with your team at the beginning of every year, find out who's still with you, who's left, put in new names, phone numbers, email addresses, etc., and discard others to make things are up to date. Because, again, the life safety people, CMS, they ask in many instances to take a look at your EOP. And then they'll go down and they'll say, who's this person? And if you've not included the new person in that position, it makes kind of look as if you're not prepared.
Very true. And we're going to work on updating that today and kind of get everyone set up for success here. All right. Our last slide on the DRC updates, I think. Yeah. Is Providence St. Joseph's over in Northridge, I think. And
Burbank.
Let's see. So at that meeting, they reviewed the Mohawk program, which we have discussed before, but again, the Mohawk, that stands for Medical Health Operational Area Coordinator. And so since LA, and each county has one, but since LA County is so large, they really rely on ReadyNet to kind of gather that information that you would normally report to the Mohawk, but you're still required to have that information ready in your EOP.
Yeah, and for LA County, because it's so large, we have an actual Mohawk, meaning somebody whose title is the Medical Health Operational Area Coordinator. But that person doesn't actually do the facilitation of all these disasters. Because the county is so large, we need dozens and dozens of people that are technically the Mohawk. So that stuff is all coordinated through the Medical Alert Center. The Medical Alert Center is what you should have in your communication plan as a point of contact for resources and such like that. So once you've exhausted your internal resources and your external partners can no longer help you in managing an event, whether it's a resource or a transportation or whatever it is, these are the folks that have the keys to the kingdom, more or less. They don't actually, for the most part, they don't maintain resources, but they facilitate the movement of resources from where they are to where you need them. So they're extraordinarily important in our state. They're the coordinating body that assists with the response for medical health, meaning all long-term care, all acute care, all hospice, all that stuff. It all goes through them. So it's important to understand how to get a hold of them, no matter what the situation is, multiple means of getting a hold of them. So it's really important.
Yeah, and if you're looking for that information for the Medical Alert Center or the Mohawk, and kind of the structure that Jason was just describing, if you go onto our website, the LA County page, you should find our LA County resource guide that will have those phone numbers and names and everything you need in there.
Yeah. And then that second point is I've not heard this before, but this is something that was borne out. So that consider developing MOUs with local hotels or motels in order to help your staff that may be displaced because of a disaster. I know this seems like next level stuff, like maybe this won't happen to you, but this has happened pretty consistently the last 3 or 4 real large major events where we've had a significant number of employees either displaced or could not, or the transportation around getting to work was so impacted that they literally had to have motels or hotels close to where the buildings were just to house their staff, because otherwise their staff wouldn't have been able to get in and out. I'm thinking specifically of Santa Barbara and Montecito, when the 101 was so badly damaged that they couldn't get staff in there. That
people were riding in on bicycles,
trains. The train was so overloaded. Boats, planes, you name it. And I'm not joking. There are people that were taking helicopters to work. They were ferrying people by helicopter from Los Angeles to Santa Barbara. So it did happen, and it can happen. But that's if we could have an MOU with a local hotel or motel where we could house our staff, I think that would be a good thing. And that way it will protect us a little bit from being price gouged after the disaster if we're trying to secure those hotels.
Right. And for any ICF providers that are listening in today, I'm sure that you may be familiar with stories of ICFs that have evacuated to hotels and motels because they have living facilities that you can use in a pinch. And so not just for staff, but if you have ICF or DD clients as well, if you find a place that kind of suits your needs at the very basic level, consider just bringing up an MOU with them. That way, again, you don't get price gouged when everyone and their mother needs to go stay at the hotel.
Yeah. And then the last part is to develop extensive MOUs. We've hounded this. It's impossible to have enough MOUs, I think, to effectively cover every facility that your residents may go to in the event of evacuation. It's really difficult to do. I think you want to have a number of them, because if you have an emergency at your facility, let's say you have a water leak and 4 of your rooms become flooded and you need to move 8 people out, and it's only going to be a week until you get it, the floor pulled up and fans put in and new flooring put on. That those MOUs are very, you can use them all the time. This makes total sense to have a relationship with the people that are closest to you. I don't know if 30 or 40 is appropriate. I don't even know if it would be enough. You may have 30 and none of those people may go to any of those 30 buildings. I don't know. But have some with the folks close to you. You got to check that regulatory box. Have some folks that are farther away from you. That will check that regulatory box. But also have a copy of a blank MOU, or understand what we're talking about in the MOU and how you can do that during a disaster or after the disaster. So we want to talk about who's going to get paid what and when they're going to get paid, and what are you going to support those services with. Are you going to send staff? Are you going to send supplies? How long is it going to be? Are you going to discharge them, or are you just going to do a temporary transfer? So if you look at the MOU template that we have, all that language is spelled out. Since it's not a contractual obligation, there's no law, it's not a binding contract. You could potentially use our MOU on the back end with somebody that's already received your residence, provided that they have an understanding of not to do an intake. They're not accepting these people at first, or it's a temporary transfer. So you can do it on the back end, have enough to meet the regulatory requirement in your plan, and then be prepared to do that on the back end afterwards.
Okay, and so this slide here just shows the next round of hazard vulnerability assessment meetings. And of course, the Henry Mayo one was rescheduled to tomorrow, so that wasn't captured here. But if you are up in the Santa Clarita or Valencia area, tomorrow is your HVA meeting at Henry Mayo. And so I apologize for sort of the frenetic pace that we're going at today here. So we're going to keep moving. This information is available in the slides that were emailed out to the attendees last night. Or you can hit print screen really quick, but I'm going to move on to our next section of the webinar here. And so now we're going to talk about the Nursing Home Incident Command System. And thank you, Rich, for attending all these meetings and being such a great resource for our long-term care providers that attend those meetings, and joining us on the webinars.
My pleasure.
Yeah, we've got probably like an hour's worth of material. We're going to try to pack into a half an hour here. So if I go really fast with you folks, please forgive me. We did like a NHICS explainer class at the conference a couple weeks ago, and our plan is to have a more robust training, so folks that are new to incident command or nursing home incident command can get a bigger chunk of this. But we're just going to cover what NHICS is. You've heard the term incident command maybe, or you've heard the term NHICS before, but NHICS stands for Nursing Home Incident Command System. And incident command in itself is just a system of predetermined staff roles. And it helps to document activities, and helps you to manage by objective. And that's really the goal here. And I think after you'll see some of this beginning stuff, you'll be able to see that, oh, we practice incident command already. We just don't call it that. We manage our incidents, or we manage things by objectives. We have goals that we want to meet, and we set out procedures to help us meet those goals. That's kind of what incident command is in a nutshell. I've cut out the definition, a physical definition from FEMA, and that's under that first bullet point. And then the second bullet point here is to understand that NHICS, even though it's not required in the CMS EP requirements, they have a bunch of requirements for things that NHICS or incident command will help you meet. So
yeah, they basically describe it and just don't call it that. So if you look under ETAG 7, they talk about having predetermined staff roles, succession plans in the event of an emergency. And this is really kind of the backbone for your response and your business continuity as well.
Yeah. So I don't want to give too much, but we've got the fire service in Southern California to thank for the adoption of ICS. It really is based on a military hierarchy. You can look at military command systems from before the First World War, and they were using a similar structure to organize themselves before that. But it wasn't until the 70s the California Fire Service did it here to kind of streamline mutual aid between different departments when we're fighting these large-scale wildfires. And the last point, everybody, and when I say everybody in the response world, everybody uses ICS. We all integrate into unified command in the event of a disaster. Whether you know it or not, that Mohawk program we mentioned, all public health falls under those same categories. So it's unity of command, common terminology, management by objective, and we'll talk about how it's flexible and modular in a second. So we've got what's called an incident management team, and these are all of the roles within that incident management team. Now, we've got acronyms that help us realize who, remember the chiefs in the sections. I use the FLOP acronym, Finance, Logistics, Operations, and Planning. That helps me realize the four major categories. And then the command staff up at the top, the liaison or PIO, safety officer, medical director, those are all folks that report directly to the incident commander. And then when we redid NHICS, we thought it was important to have a set aside role for a scribe or a runner, somebody who's responsible for capturing data and information to assist the planning section chief and copying all this information down, make sure it's captured it correctly.
But in the event that all of your communications go down and you can't use, electronic communications, the scribe would also be, your kind of communication link there. So he's also the runner.
Yeah.
And so if you are looking at the handout for the IMT chart, you can see that this is exactly what we're going to be filling out today. And so we will dive right into the incident commander.
So obviously everything starts in incident command with the incident commander. Incident commander can be the only person activated in a disaster. So not every disaster requires all these different branches and chiefs and command staff and all that. When we said it was flexible and modular, it means it's flexible and modular. The only person that's always activated is the incident commander. So the incident commander activates and directs the response. They're the ones that establish the priorities and objectives. Obviously, with input from that incident management team, those section chiefs that we talked about earlier. I know this sounds familiar. It sounds so bizarre to some people. I promise you it will get more clear the farther we get into this. But that incident commander is responsible for determining who needs to be activated in that incident management team, and they'll assign the roles as well. To give you an example, let's say you had a missing resident. You may have elements within your incident management team activated, but you wouldn't activate everybody. There's no need to activate somebody for the finance and administration section or the medical director or some of these other things. When you're managing such a small event, it's scalable. It flexes up and flexes down.
Buddy, go.
And so,
before we move on, if you have that IMT chart in front of you, just think quickly about who you would want sort of responding to the emergency, who would be in charge of delegating out the roles. Usually people that fill this role are the administrator, but we also see sometimes it's the executive director, sometimes it's someone at the corporate office. It's really customized to what your facility or your organization wants to do.
Yeah, and the incident commander should always be the person with the most experience. That's I know we say the administrator or something like that, but if you've got people that have been through this before, maybe 30 or 40 years of service, or maybe they were in the military before they came to you, and they're familiar with managing an operation during a stressful situation. Those are the folks that we would suggest. So regardless of where your corporate hierarchy lies, we would suggest that the most experienced person fill the higher roles in incident command.
And these three smaller bullet points here, the PIO, safety officer, and medical director, those are all tasks that the incident commander is responsible for unless they delegate those out specifically. So if you don't have someone set as a PIO, the IC is, the incident commander is the PIO and the safety officer.
I would say in my experience, it's extraordinarily common that the administrator would fill most of those roles. In some facilities, the physical plant director or maintenance director would be the safety officer because they'll be able to understand physical plant safety issues maybe better than an administrator would. But those are the folks that traditionally fill those roles.
We kind of described this already. So the incident commander determines the objectives for response and recovery. So imagine that it's 10 a.m. and it's been raining cats and dogs, and so suddenly it starts flooding in your dining room. And the incident commander has to decide what you're going to do now, what you're going to do next, and then start sort of delegating those tasks out to your predetermined staff members who would fill those chief roles, that sort of second tier down there as well. And then at the end of every operational period, which is another part of incident command, usually it goes like 0 to 2 hours and then 2 to 12 hours, you would be reassessing your objectives as the emergency continues. And so like Jason was saying, the incident command system is meant to be flexible because you're going to be dealing with a lot of different hazards. So for flooding, your emergency might last a couple days. Active shooter is more of a rapid response sort of thing where you're not going to have sort of time to, determine your objectives. No, like everybody needs to be going to those immediate reactions, and hopefully you have done a drill on active shooter, but we won't get too far into that.
And the last bullet point, as the response evolves, this is extraordinarily common that you could find yourself in a situation in which you're dealing with an emergency scenario or some kind of natural disaster, and the risk has changed. You're either safer now than you were before, or you're more at risk than you were before. And Incident Command offers you the ability to, switch response from, let's say, shelter in place to evacuation. And it allows you the ability to change objectives and change the strategies. And then folks have a predetermined, kind of staff roles. Okay, you're the logistics chief. Here's your checklist. I want you to go take this checklist, accomplish everything on the checklist, and come back to me in an hour and let me know it's completed, or 15 minutes, or whatever it is. But it gives you the flexibility to move from evacuation to shelter in place or something like that as the response dictates.
And then one more thing about these predetermined roles. Say your emergency is going on for longer than what your staff is scheduled for. With these sort of predetermined checklists and roles, they're able to hand that off to the next person coming on board, and your response can continue without interruption, or as little interruption as possible.
So I mentioned the FLOP, meaning the section chiefs or the incident management team that we talked about. The FLOP means, or the F in FLOP stands for finance. And then the finance folks will track payroll costs, any expenditure. They'll purchase supplies. Let's say you're in a disaster and you're sheltered in place and you need to get diesel fuel. Well, the person that's a finance chief would be responsible for paying for that diesel fuel and making sure that had money in your petty cash, something like that. We all know that during disasters, and the ATMs and things like that will probably go down, so it's always good to have some cash. Those folks would be responsible for that. And these are the people that are really important on the back end in terms of capturing information, cost recovery, whether we'll be able to seek reimbursement from FEMA, how do we document that stuff, capture all our expenses during the event. For an extended response, they're extraordinarily important. Go to the next one. I'm sorry, I got to get through this in this episode. So logistics folks, the L in the flop, these are the getters. Finance are the payers, the logistics folks are the getters. So how are you going to, we talked about needing diesel fuel. The finance person would pay for it. The logistics folks would go get the fuel, right? So they're going to maintain those supplies in your facility, things like that. So if you think about it in terms of think about people in your building, who would be good at finding all this stuff? And do you have the necessary information to help them go about that business? So if you said, here's a checklist. I want you to secure transportation for our evacuation. I want you to make sure that your transportation is appropriate to what it is. I want you to make sure that the DME that's going with each one of these folks is all set and ready to go. If you think about that, it's these are the folks that kind of move stuff around during operations during a disaster. If we'll talk about planning in a second, this kind of forward-looking thing, but the logistics folks are your getters.
Yep, they're kind of the glue that makes the planning and the operations come together. Is how a good way to think of it.
Yeah, and so the O in the flop stands for operations. This is the doers. If you think about it in terms of what you do in your building, this is the 800-pound gorilla, or however you want to say it, but the operations is by far the biggest section of your building. So if we look it's so big that we've had to break it down into different sections. And the reason why we did that is because the folks that would be good under resident services might not necessarily be good under the infrastructure branch, but the folks in the infrastructure branch probably wouldn't be real good in the resident services branch. So we had to kind of, divide it out when we redid NHICS. And so think about who would fill those operational roles. The resident services person, they're going to be responsible for admission and transfer or discharge, any nursing, the psychosocial needs of the people in the disaster, making sure that the medical records are up to date. If you do EHR and you lose power, do they know how to chart, through handwritten charts? Because some people have forgotten that. And I know Rich had put that on his update that some people have never physically handwritten a chart. So make sure that they're familiar with how to do that if you lose power. And then the infrastructure branch, maybe it's a dietary manager or a physical plant director or director of environmental services, somebody to oversee the infrastructure, the physical plant of the building. That's the folks in operations, right? And then last person in that flop are the planners. The P stands for the planners. They'll collect the information. So we talk about situational awareness. This is one of the most important things for you to help you when you're managing a disaster, is to have this kind of ongoing stream of information that may affect how you change objectives. And I'll give you an example. In the campfire, November of last year, when the facility found out that there was a large fire near their building, they activated their evacuation plan pretty quickly, and they started calling for transportation resources. But somewhere in the middle of the time that they called for the transportation resources and when the transportation resources could get there to evacuate them, the evacuation routes were compromised. So they had to change their plan from evacuation to shelter in place because they could not leave. They could not safely evacuate, which is an odd thing. And then somewhere, maybe an hour or so after that, the sheriff's department came and said, you're not getting any ambulances. You have to go in your personal cars, and you have to go now because the building's going to burn down. And so it's that kind of collection of information that helps the incident commander make those decisions as to changing the objective. So those folks went from safely evacuate every resident as an objective to safely keep everybody in the building as an objective to then transitioning back to safely evacuating. So it was necessary to have a method to be able to change that stuff, and not to mention how important that kind of situational awareness is, monitoring everything you can, especially in a fire. The messaging that goes out is not great. It doesn't come timely. You may get it way after you have should have already committed to making a decision. Understand that, but it's extraordinarily important to do all you can in terms of that situational awareness during the event. The planner is also responsible for preparing that incident action plan, and capturing all this information is really, really important if you ever hope to seek reimbursement from FEMA. I realize for-profits can't seek reimbursement directly, but the county, that Mohawk program, the county can get reimbursed for the movement of those medical supplies in a disaster. And so if you're going through the proper channels to request those resources from the county is going to get reimbursed eventually for those things, and you wouldn't be stuck with the bill. So it's important that you understand how to capture this information, because this could cost you tens of thousands of dollars on the back end if you're not capturing this information correctly.
Jason, if I may interrupt,
yeah.
One of the things that was talked about was that in the campfires, that people's private goods, TV sets and things of this nature were destroyed or damaged. It might be worthwhile on the front end nowadays, because we have phones that take pictures, to document this is the TV set they have, this is the equipment they have in the room that is theirs, so that the way that they are reimbursed, or so that they can get reimbursed later on in the future without too much hassle.
Yeah, and that's a part of that continuity of operations planning that kind of goes hand in hand with incident command structure and your emergency operations program. It's, we had somebody come speak at the conference about, kind of insurance things that you should have questions of your broker before the event, not after. Find out about where your coverages lie, what the restrictions are, what they need from you in terms of proving those expenditures. Find out what you'd be covered for loss of use. Does it cover for payroll of your staff if you're out of the building? I don't know. There's a lot of questions you have to ask your insurance provider. Maybe that's a category we should cover in a future webinar, is to have somebody from the insurance industry. I'm not a insurance broker, so I can't give you coverage advice. I think that's actually against the law if I do that. But I would say that at the minimum, you should be having a conversation with whoever you get your insurance from to find out what your limitations of that coverage is, and how to protect yourself financially. Because CMF, they want to make sure that you continue operations to provide care, but they don't necessarily care that your business stays a business. In 10 years from now, if you're not in business, CMS doesn't care about that. I mean, they'd love to have the beds, but ideally, they only care about your continuity of operations, meaning how you can provide a safe area of care for the folks in your building. Outside of that, there's no requirement for you to figure out how you're going to keep your business running after that. So,
correct.
Okay, just a couple more rules here, and then we will be checking for questions. So, Jason, did you want to cover this one, or do you want me to?
Yeah, so we had mentioned at the beginning, these folks are command staff. They can be activated, or the incident commander can perform these services by themselves. I think it's probably pretty common for this particular position, since we don't have tons of staff and we don't have a dedicated PIO in our buildings, not normally, it's almost always going to fall on the incident commander. I just want to let you guys know that CAHF has a dedicated public relations staff. So if you ever find yourself in the need of PIO or some kind of messaging, especially around your response to a disaster or emergency, by all means contact us. I'm not sure we got all the information, but at least we can help you from getting sued. And maybe, if there's a public image problem with how you responded to a disaster, please let us help you craft that message. During a response, most of the time, we would recommend if you get contacted from the media during a disaster or an emergency, I would always refer those folks to the public information officer at the medical alert center. So in Los Angeles County, I would refer them straight to them and say, look, our county public health has a public information officer that's willing to speak about, in generalities. But I would never, in the event of a disaster, speak with the media voluntarily. And I would discourage our residents or our staff from doing it as well. So usually nothing good comes from that. I've not seen any positive kind of PIO messages or positive messages coming from the media after a disaster outside of some of the stuff we saw from the Paradise Fire. Most of the time they're looking to find a hole or something like that to point a finger at somebody. And generally it's not meant to assist you in any way, shape, or form. So we would suggest deferring that information to the medical alert center if you're in a disaster. Safety officer. Some would say I have people that do incident command all the time at their buildings, not just for disasters. They do it for survey. They do it for a number of other things, but they practice incident command. And one of my friends always says the safety officer is the most important person in there because they're the only people that can stop complete operations of the response based on a risk that they've identified. So with that being said, whoever your safety guru is or your safety person, the person that we all know that person. I'm that person here, but we all know that person that looks at the safety of the building as their personal project. Those are the folks you want as a safety officer. Somebody that is familiar with the physical plan, the structure of the building. Physical plan directors are great for this role because they understand where things lie within the building, what presents a risk and what doesn't. That your safety officer or your physical plant director would be able to tell if that gas pipe that comes out of the ground that goes into your building is not the way it used to be or was yesterday, right? Only he would know that because he sees it all the time. Only he would know, whether those cracks in your stucco represents new stuff or was that settling from 20 years. Who knows? But my point is you want somebody that's familiar with the physical plant that of your structure to be your safety officer, and it may be you can't spare that person. You need that person to be the infrastructure branch chief or to assist operations. In that case, then it's going to be the incident commander who also fills that role, who oversees that stuff, and then they have the ability to literally stop anybody from working. So, and the last one is the medical director or specialist. Most of us don't have medical directors on site during an emergency or disaster. It may happen to be that you would have one there at that time, but it's not normal. So some of this stuff may need to be done over the phone with this person overseas, especially in terms of advising the incident commander regarding medical or biological or infectious disease risks, hazmat implications. Most of the time, we're going to see the incident commander fulfill this role as well, simply because that medical director or specialist is not there in the building. So
we see a lot of people make their operations chief the director of nursing, but something to consider is when the emergency is going on, it's a very stressful event for your residents, and monitoring the ongoing conditions of your residents as everything's going on would fall under the medical director. So if you're able to, maybe appoint this to your DON so that you can have someone who has the knowledge and expertise to assess the health and condition of your residents, and then inform the incident commander if you need to change your objectives based on, like it's getting too hot for our residents, we need to move from shelter in place to evacuate. That's kind of another part another facet to this role here as well.
Yeah, Courtney brings up a great point. If you look at what the typical kind of responsibilities for the medical director are, if your administrator or incident commander are not comfortable in making medical recommendations or biological or recommendations based on a perceived biological or infectious disease threat, then definitely pass that off to somebody that has a higher level of training or healthcare training. So.
Yeah, I think the title medical director is a little bit misleading here because there is already a person in your building called that.
You're
and
right.
It's usually like a doctor that's like in a remote location. But under ICS, this person does need to be able to assess medical conditions and then report that to the incident commander.
Yeah, and she also brought up a good point about having that DON in a capacity to be able to oversee the medical conditions of the residents as they're being moved, if we're talking evacuation. That's one of the things that maybe falls through the cracks, and certainly with some pretty tragic outcomes if we don't do it correctly. So.
And we just came out with a toolkit on care considerations as well, so maybe that's another webinar that we need to do. But anyway, moving on so that we can get everyone through the webinar on time and address your questions. And let's see. So then our next slide, just kind of reviewing the flexibility of NHICS. So with the sort of branched out way of incident command, again, delegating the different positions is up to the incident commander, but also particularly under operations, because that's usually, like Jason was saying, the most active part of the FLOP or the section chiefs. You don't want to have the operations chief overseeing like 10 or 15 people.
Right.
You want to start breaking it out into manageable chunks and having that sort of flow of information be organized, because it will be total chaos when something a disaster actually happens, especially something as large as some of the wildfires that we've seen, or even some of these planned power outages that are going to be kind of the new normal for skilled nursing facilities.
So a part of incident command is having a place to work for your those incident management team staff. So I think everybody here, hopefully you've got an idea where your command center is going to be in your building. If you don't have an idea, think about where in your building this is going to be. It has to be safe and secure. It has to have adequate technology. Access to bathrooms is important. Needs to have red plugs and emergency lighting. That's absolutely critical, because not every disaster happens in the middle of the day. And basic office supplies. The NHICS documentation forms, you can either have hard copies or you could have electronic copies. Facility maps and floor plans, so that you know how to get out of there if the building becomes compromised. Obviously, have a copy of your emergency operations plan and a whiteboard or chalkboard or something that you could write on and have status information posted. So, and I'm not sure we have time to get through this whole thing, but I want to give you just click through these things, and this is how response would go under incident command. The day one emergency happens, incident commander is activated, and they activate your emergency operations plan. Depending on the size of the thing, they would assign staff roles, and they would decide to, go forward from there. And as you can follow it along, so we've got that rapid response, or that says immediate response. It should say immediate. Oh, it does say. I'm sorry, I had a brain fart there. Immediate response is 0 to 2 hours. But this just shows all of who gets activated and what they get activated with. Operations chiefs, just-in-time training for staff. Are there things that your staff don't normally do, but you need to counsel them on how to do this? Let's take something real simple, like you don't have go bags prepared, but you're going to have go bags, for each one of the residents. So you give some just-in-time training to a CNA and say, I want you to go to each room, and these are the items I want you to put into this go bag for each resident. that's an example of just-in-time training that the operations chief would do. And so we broke this down into operational periods. At 0, the first 2 hours is the immediate response. Intermediate response is as the thing progresses from 2 to 12 hours. And we talk about, kind of monitoring things, ensuring that continuity of care. If things go sideways, how do we change that? But this just gives you an idea of how things would continue to go if the response was 12 hours or longer. And you see the kind of the objectives. Some of them stay the same. Some of them will change. And then as you get to I'm sorry, I'm going to go back one slide. So I can't really see these slides over on the end here, but as you get to the end of your operational periods, then you would transition it into that recovery with business continuity. Obviously, if you're repatriating back into a building, you're gonna have to get permission from public health before you are allowed to do that, to go back into the building. They're depending on the type of event, they're going to have OSHPD come out and take a look at the building as well. So,
and you can see at the end on the right-hand side there, it says Update Incident Action Plan, and then the event continues. And so our next webinar, we're going to be talking more about incident action planning. And again, I apologize for sort of the packed hour that we had, but we had a lot of stuff that we wanted to share with you today.
And we'll stay on for questions. I know we're right at an hour, and if folks want to tune off, they certainly can. But we'll stay here and answer any questions that we have listed on the thing here.
So again, we are going to take a look at the questions panel now, but this is the conclusion of our webinar. So thank you for joining us, and see you all next time.